Good day, everybody. Welcome to our fourth webinar in our COVID-19 series. First, I'd like to acknowledge the incredibly difficult times our country has been facing and express thanks to all of those on the front lines for battling this epidemic. In some parts of the country, like New York, we have hopefully seen the worst, with a small light now appearing on the horizon. In other parts of the country, the epidemic is still on the upswing, with likely growing difficulties ahead. What we know about this epidemic changes daily. At EHE, we don't profess to know the answers. What we can do, however, is help our clients contextualize the enormous amount of new information as it comes in, so that you can better plan to keep your employees safe and your businesses operating in the best way, given the current knowledge base. Answers tend to be easier than the right questions. Today, we will be discussing a number of questions as we think about returning our employees safely to work and restarting our businesses. Understanding how this epidemic came so quickly and dangerously upon us can provide insight into what we need to do to restart our economy. For that reason, we have invited Dr. Justin Silverman to give us this perspective, from which we can hopefully strategize sensible, safe-at-work tactics. Dr. Silverman is an assistant professor in the College of Information Science and Technology, as well as the Department of Medicine at Penn State University. He received his MD and PhD from Duke University. He has expertise developing predictive and inferential models to support clinical decision-making based on electronic healthcare record data. Recently, he focused on using surveillance network data from Sentinel medical practices to estimate the prevalence of COVID-19 within the United States. He is the lead author on a recent study using influenza surveillance networks to estimate state-specific COVID-19 spread in the United States. Of note is that this article that he'll be discussing today is under active peer review, but it does add to a growing body of evidence describing the actual spread of the epidemic in our country. Our second speaker, back again from our last panel, is Delphine O'Rourke, a partner at Duane Morris. She is trusted counsel to health industry leaders. She advises healthcare companies, hospitals, and systems, as well as investors on the regulatory frameworks that drive their healthcare businesses. She is a regular speaker and contributor to legal leading and industry publications and podcasts, including Modern Healthcare, Law 360, and the American Health Law Association. Today, she will discuss balancing business continuity, employee concerns, and public health during this pandemic. She will talk about informed consent for elements of your safe return to work strategy. And she will talk about and describe the importance of a documented, segregated, and controlled COVID-19 return to work strategy. As usual, we will try and limit the comments to about 20 minutes to half an hour. There will be a few charts and slides. There will be ample time at the end of the presentations for questions and answers. Simply ask the question via Zoom by clicking the Q&A button on the bottom. After the webinar, please note that you and your employees should feel free to reach out to us via our COVID hotline, or you can call us anytime toll-free at 844-258-1820. So with that, I will give a little bit of an overview of where we stand from a pure epidemiologic point of view. I'm getting to be pretty good at the screen share. This is our agenda for today. I'll talk about when and how we get back to work, a little bit, an overview, and then we'll talk just a little bit about tests because there appears to be a lot of confusion in the marketplace around that. First, let's discuss when. The key issue with respect to getting back to work is understanding when we are on the backside of a curve versus when we have been on the upside of a curve. R0 is a technical term in epidemiology, which really describes the reproductive number in susceptible populations. In other words, how many people generally are infected by one person, or how many people many people can one person get the disease from any given individual person. For COVID-19, we're now realizing that that number is about 5. That's a moderately contagious disease. Given a disease like measles, for example, which is much more contagious than COVID, any single person that has measles with symptoms can cough in a room and give the disease to up to 15 or 20 people. Even though COVID is less contagious than measles, one of the things that distinguishes this epidemic, and Dr. Silverman will get into it, is that COVID distinguishes itself almost like a secret and invisible enemy, like a Trojan horse, because large numbers of asymptomatic people with COVID can in fact transmit it to many other people. And as we talked about last time, it turns out in China, and now we're learning in other places, at least 80% of people who get COVID get it from people who are innocently carrying the disease and have no idea at all that they're spreading it. In an epidemic, the R naught is greater than 1. In other words, there's more people getting the disease from one person than not. And the curve goes up quite dramatically, logarithmically. As you can imagine, if one person gives it to 5 and those 5 give it to another 5, you get a very steep curve. When the curve flattens, by definition, one person is giving it to one person. And then we call the R naught 0. It's a flat curve. On the backside of the curve, it takes actually more than one person to transmit it to one person. In other words, 10 people might give it to 7 people, or 10 people might give it to 2 people. And it's at this back end of the curve that we know that the epidemic is involuting and shrinking, and that it's likely more safe to return to work. So we're focusing, when we look at how to return to work, around when to return to work and in what geographies. The idea here is to focus on when the epidemic is slowing down, is not building, but is declining, and a whole host of other factors, which we can talk about potentially in the question section, like what the hospital infrastructure looks like, are hospitals overwhelmed, and the like. On the how side, I think most folks need to understand that tried and true public health tactics are not just one thing or another thing. It's really a total system. It begins with testing, then quarantining, then contact tracing, then quarantining the close contacts, and then managing this an entire system. And when you look at what successful countries that have been able to contain the epidemic in a significant way, places like Korea, South Korea, Taiwan, and now Germany, you can see that what they've really focused on is understanding who has the disease versus who had the disease, focusing on excluding those people from any kind of environment where they could potentially give it to someone else, at least for the length of infectivity, which maybe is 2 weeks or maybe even 3 weeks, to vigorously contact trace every person who that infected person may have come into contact with. On a work situation, that would be the employer's responsibility to understand with whom that person has met or with whom that person is clustered, and then obviously reporting it to a public health authority to deal with the community issues. Once you find the close contacts, to exclude those from the work environment, send them home, make sure you retest them to make sure that they're COVID negative, and then bring them back. Otherwise, if they're positive, to keep them out of the environment. And this is a continuous management cycle that has to be done every single day, not testing every single day, but certainly monitoring every single day. And ultimately, what we arrive at is a continuous management system. And what I like to say is you whittle down this curve. You whittle it away, you whittle it away, you whittle away until you get the epidemic to arrest itself by eliminating chains of transmission. And lastly, I'll just say a couple of words about tests before we move on to Dr. Silverman. There's been a lot of confusion around tests in this environment. And so let me give you an overview, and frankly, one can talk for hours on the status of testing in America. Literally, we are learning so much new every single day about the value of some of these tests. But let me just say that there's 2 major kinds of tests. The PCR test, which is what we call, or people have called, the diagnostic test, focus on detecting directly the RNA of the virus itself. So that's a direct presence. It's usually tested by a swab that's put in the nasopharynx, which is through your nose into the back of your throat. When well sampled, there's a high sensitivity and specificity, at least 95% sensitivity and specificity. So it's a good test. It doesn't give you a result automatically. You have to send it out to a lab that has the required analytic capability to understand if it's positive or negative. And as we know, there are some issues about that test today. Most importantly, that there's enormous shortage of those kinds of tests. The other issue with those tests is that it's really difficult to get a great sample. We have been seeing reports, and I'm sure you've all read about these reports, about up to 20, 30, 40% false negatives. And what that means is, and the reason for this is because it's actually hard to get a great sample. And for those of you who have ever tried to put a swab down the back of your nose to your throat, you can imagine it's not an easy thing to do. And the times that you get the best results of these tests is when doctors actually put some of these swabs all the way down into your trachea and really down into the back of your throat, really deep, to get the right kinds of samples. The other kinds of tests are antibody kinds of tests. They likely have the same kinds of sensitivity and specificity to the PCR tests in actively sick people, meaning that when companies who have looked at the sensitivity and specificity and directly compared them to what happens inside of a PCR test, when somebody is actively sick, they appear to perform in the same way. The problem is we don't know how they perform in asymptomatic people who are just carrying the test. We're now seeing some emerging data. There are two kinds of antibodies in the antibody test. The acute phase reactant, which is the IgM test, which says when you actively are mounting a response, namely you have actively the virus inside of you. And then the recovery phase of the antibody, the IgG portion of the test. Some of the issues with the antibody test, particularly the IgM test, is you can imagine you probably have to have the virus inside of you for 2, 3, 4, 5 days before you'll start to mount an antibody response. So for this kind of test, there's likely a lag of a few days compared to the PCR tests with respect to identifying the antibodies. But remember, with respect to two antibodies, the IgM tells you if you have the disease, the IgG tells you if you had the disease. And those are the kinds of considerations we want to think about as we plan a return to work strategy. Lots of discussion out there about how long do you stay? Are we immune once you develop IgG or not? Well, if anybody can tell you that answer, they're probably not telling the truth, because this is new to human species, this virus, and it's only been around for 4 months. Other coronaviruses tend to have a 1 to 2 year minimum type of immunity, but we cannot say for certain. We hope so, but data will emerge in that regard. So that's an overview of the basic epidemiology of what we're dealing with the ideas and the questions we should be asking as we think about a return to work strategy. And now I'm going to pass this and flip to the next slide to introduce Dr. Silverman, and he's going to start to discuss this very interesting paper that was just published a couple of weeks ago. Thank you very much, Justin.
Well, first off, thanks for inviting me to be with you guys today. So back in early March, a friend and I, who've been colleagues for a long time, started noticing that the coronavirus definitely seemed like it was going to be coming to the US, and that the existing testing methodologies really were not up to par to get a good estimate of the prevalence in the US. So we actually had the hypothesis that influenza surveillance networks, which monitor for something called influenza-like illness, could be useful for assessing the prevalence in the US. So the idea was that COVID often presents with fever, cough, and runny nose, just like influenza does. And so these existing surveillance networks, particularly one called ILINet out of the CDC, are this big this big network that has a number of sentinel providers spread throughout the US. And each of these sentinel providers reports on the number of patients that come in each week with influenza-like illness symptoms, as well as the total number of patients that they saw. Particularly, this is outpatient data. So we actually think this is a big advantage compared to inpatient. Inpatient, you can have the bias, you only see the most severe cases. In the outpatient setting, we get a little bit of a broader picture of who's there and potentially capturing a larger fraction of the total infected population. So that's basically the idea. So this is a data set that can be thought of as comprising a number of different respiratory pathogens beyond just influenza, as we hypothesized. It could also be capturing COVID. In addition, there's a number of seasonal respiratory pathogens that will also show up as influenza-like illness. So the first thing we had to do was try and separate what part of the data is coming from influenza, what's coming from COVID, and what's coming from other stuff. So if you could please go to the next slide. So what I'm showing here is an example of the data for 4 states. In red, this is the proportion of patients who come to their outpatient providers and say, I've got fever, I've got runny nose and cough. And you can see that there's this kind of regular pattern to it. In the winter months, there's generally a peak. There's the 2 humps that we typically see from influenza. So the first task was to remove the influenza signal. We did that using laboratory surveillance data also maintained by the CDC. And what you get after you remove the influenza is the blue line. So this is influenza-like illness that cannot be attributed to influenza. Then I used a probabilistic model to basically learn what is typical seasonal variation for the non-influenza ILI and subtract that out. So now what you're left with is the green line, and this can be thought of as all of the patients coming to their outpatient provider that can't be explained as flu and can't be explained as typical seasonal variation. So we call this the excess ILI. And what we found is that starting March 8th on, this excess ILI correlates extremely strongly with the spread of COVID throughout the US, being high in states where there was a number of confirmed cases, and relatively low in places where there hadn't been confirmed cases. So for example, in New York, we saw this particularly large surge of this excess ILI corresponding to the similar dates to when New York was peaking in the number of new cases per day. If you could go to the next slide. So the next task was to try and estimate, so given this surge of excess ILI, trying to actually get back to a prevalence estimate. So the way that I like to think about this is, basically what we see is just the tip of the iceberg, and we're trying to estimate how big is the iceberg under the water. You can think of it as in a given week, there's a number of patients who are exposed. Only a subset of those will go on to be infected. A subset of those will then go on to be symptomatic. Only a subset of those will then go on to seek medical care. And this is where we start to be able to detect them once they start presenting to the healthcare system. And particularly ILI, this influenza-like illness, can be thought of as being a subset of those who seek medical care. And as I said earlier, this is outpatient, so likely capturing a larger portion than just the confirmed COVID cases. So essentially what we did is we used something called a multiplier model to first take this ILI and sequentially estimate the size of these different components, basically estimating how big this iceberg was under the water. And what we found was that while between March 8th and March 28th, there was only 123 confirmed cases, we find that there's over 8.7 million suspected infections based on this ILI data, right? So basically just about 80 times more cases than what we were seeing in the official case counts. Okay, if you could go to the next slide. So high prevalence is one part of the story. The other part of the story is the fast growth. Initial reports out of China that were also spread by the CDC and the WHO suggested that the early growth rate estimates were really closer to 6.1 day doubling times early in the infection. This corresponds to an R naught, as David was talking about, of only 2 to 3. As time has gone on, it's become clear that that isn't the case. In fact, early in the epidemic, especially in the US, this was growing faster than every 3 days. So the difference between a 6-day doubling time and a 3-day doubling time, when we're talking about over the course of a couple months, you have many more doubling times. This is a massive difference. So really what we're seeing here is that we've got high prevalence and fast growth. And so together, this actually suggests that we have to think about coronavirus and COVID in a little bit of a different way than what I think what's currently being portrayed in the media. Rather than a disease that is defined by how deadly it is, which, just to say, it is still a major health concern. But really, I think that the truly remarkable thing about this virus is how many mild and asymptomatic cases there are and how fast this can spread through the general population. What we see is that hospitals are overloaded because this happens so quickly. And even just the tip of the iceberg, when it comes at you that quickly, is enough to overwhelm hospital systems. But still, essentially having, as many people are talking about, the larger denominator, this much larger portion of people being infected, does suggest that the actual infection fatality risk is likely lower than originally reported, likely by an order of magnitude. Importantly, though, this isn't to say that this isn't a dangerous disease. It can overwhelm hospital systems, and even at 0.15%, this still, assuming that ultimately 60% of Americans will contract this disease, this still corresponds to somewhere in the order of about 300,000 deaths.
Super, Justin. Thanks for reviewing that. I just, before we jump into Delphine, I think for employers, it's really important to understand the nature of this because, as you look at New York, perhaps you could say that the toothpaste is sort of out of the tube and probably hard to put back with thousands and thousands of lines of transmission because we've been overwhelmed, as the data has suggested. But that doesn't have to be the case. There still are, most areas of the country have fairly low amounts of cases, and the kinds of containment and the kinds of detection and quarantine and public health and contact tracing, those kinds of things, in fact, can impede the growth of this epidemic. And the most amazing thing about this data, which frankly has been supported by several other antibody studies that have been published in recent weeks, is that there are way more cases out there than we had originally even imagined, and that this thing can really, in the blink of an eye, overwhelm a particular community and start to get into a really serious growth situation. And that's why this epidemic is so dangerous. It's important to understand that all we're really seeing is the tip of the iceberg, and that the whole iceberg below the surface really poses a huge danger. So I'll stop there and ask Delphine to talk about some of the issues on the legal front.
Thank you, David, and thank you, Dr. Silverman. I have a whole list of questions to follow up with. That was fascinating, and I'm sure that everyone else does as well, just mind-blowing. So I'm Delphine O'Rourke. I'm a lawyer, and I spend most of my time advising clients on healthcare laws, both federal and state level, that apply to their businesses. And as David mentioned, I'm a private practice attorney. However, I also served as in-house counsel with one of the largest healthcare companies in the United States, and I was part of leadership teams. So I appreciate that the laws are not applied in a vacuum and that you have your business considerations. So for context, and I think these are similar themes that you're seeing throughout in different interdisciplinary areas, is that since the Affordable Care Act, there have been hundreds of new laws in the US, healthcare laws, that many of which you've heard of. And that it's been a really challenging regulatory environment. But since the start of COVID-19, the changes in laws have been even more rapid. And keeping up with those changes, and most importantly, looking around the corner and anticipating new laws is critical. For the past 15 years, I've been advising clients on legal issues relating to emergencies that have health impacts. So, tornadoes, active shooters, disease, contaminated water, but generally those situations were addressed with laws that were already on the books. So we were applying the laws to the particular facts and circumstances, but we were familiar with those laws. However, return to work for COVID. We have new executive orders, we have federal legislation, public health announcements, county level decrees. They've all been passed in the past 7 weeks, even yesterday with a congressional bill. And then must be complied with along with your existing laws. So you have a process in place generally for return to work, and now you're layering on another level of COVID regulation. And we're doing so with little understanding, and I think Dr. Silverman's presentation demonstrated that, really little understanding of COVID, as well as short and long-term impacts, including health impacts. So the unprecedented, it's going to require really a very new perspective, in my opinion, on return to work processes that we've known and have been working with comfortably and for years, pre-COVID, post-COVID. So I'm going to address 3 issues today. And first, it's the balance between reopening the country and the huge pressure to reopen the country, the health and safety of our employees, and the public health. Second, we're going to talk about making sure that your employees understand and agree or disagree to parts of your return strategy. So making sure you have a strategy in place and that you're able to identify those points where authorization or consent, where informed understanding is going to be important, particularly in areas where you're impacting their privacy, their bodies. We talked about testing. You know, obviously, if you're going to be sticking a swab down somebody's nose, you want to make sure that they're aware of what you're doing, appreciate the consequences, and are consenting. And anywhere that you're, touching upon their rights. And that's going to be critically important, for the overall, happiness of your employees, but also for your claims exposure at the back end. And then I'm going to discuss the rapid and comprehensive process that needs to align with your strategy. And this is going to be very important to limiting your legal claims and making sure it's in real time. So you're hearing a lot of information today, and if you just have 2 takeaways from my section, I'd ask that they be the need to constantly calibrate your strategy. The image that I've had in my mind is, the old-fashioned radios maybe, where you see the person in the movie just adjusting to get the right tone, or any type of pressure situation, your sail when you're sailing, is that this is not going to be set course and go. It's going to require constant calibration as the rules change, as the circumstances change around your employee population, as COVID changes, and also as our public health policies evolve, depending how the disease is managed. And then rapid alignment. So constant calibration, rapid alignment, and we'll dive a little bit deeper into this today. Let's talk about balance. And especially in the past week, we've seen in the media, we've seen protests, we've seen governors be very vocal on the need to move back to reopen businesses. It's been devastating for millions and it's straining the economy. So from a purely economic perspective, we all want to go back to work at full capacity as soon as possible. But obviously, we also need to balance the economics with the employer's obligation to provide a safe and healthy environment. So we already know, we've been operating within a framework, a regulatory framework under OSHA, that employees have to provide a safe environment employers have to provide a safe environment for their employees. And we know that part of providing a safe environment is going to be, limiting the potential of COVID infection. That we know, okay? But what we don't totally know are the other safety issues that are coming about. We know we're hearing about mental distress. We're hearing about people who are anxious to go back to work or who are scared. And you could potentially be threats to themselves or to others. It's not just about COVID. So steps to take to make sure that no one is in a situation where they're so stressed that they would act out in a way that would be detrimental. We also don't know the long-term impacts of COVID. So when you're formulating your strategies, we're seeing that people have kidney failure, it's leading to dialysis, lung tissue damage that might also impact an employee's safe return. My point is that this is going to be evolving, and we cannot set course again and just go. And that, as both David and Dr. Silverman have stated, that we're going to constantly need to address, not just over the next 2 weeks, over the next 2 months, possibly the next 2 years. We heard that sometimes it takes 1 to 2 years to have immunity in prior epidemic situations. So this might be a 2-year process. It's not a sprint, it's a marathon. So employers have an obligation to provide a safe and healthy environment. And I think this is critical to point out because we do anticipate that the EEOC is going to come out with new guidance. Employees have a right not to perform tasks if they feel they're harmful. And there's a test to determine what's reasonable, but we're already seeing fear of anxiety claims. So employees saying their anxiety is being increased due to COVID and filing claims. And that's before people are even returning to work. So, completely anticipate that you're going to see claims around anxiety, fear of returning to work, that employers fail to protect your employees. So those claims are going to arise. What we're talking about is, and what we did, and we talked about in the last seminar, is what can you do to decrease the number of those claims? And to also be on the lookout for EEOC guidance on testing. And because I do think that once we have more guidance from CDC and EEOC, employees will have greater confidence in the ability to return to work, the safety of it, and that fears will decrease. So it's critical to have a thoughtful and documented, we're going to touch more on documented process to engage with employees and determine the best course forward. And of course, not to retaliate. If an employee says that they're anxious to come back to work, to have a process, guidelines that have been identified and documented to engage in dialogue. And as part of that dialogue theme, it's consent. So we're going to go to number 2 now. Whether it's consent or you call it authorization, every company is going to have a different work strategy based on your specific circumstances. Maybe all of your employees are in one high-rise building in an urban environment and there's one point of entry. Or maybe your employees stretch across 8 states with multiple entrances and you're going to be doing temperature sites at every entrance. Everything's going to be a little bit different. Come up with your plan and then have consistent strategies and identify the areas where you're going to say, okay, I need my employee to consent to this. If it's going to be temperature testing every morning, they need to agree to that or disagree, but that it's clear and it's documented. Same thing with testing. Same thing with, I've gotten a question recently, well, do I really need consent for a temperature test? If you're touching someone physically, that could be arguably assault and battery. And we see that in the healthcare context where patients receive treatment that they didn't consent to, and they make claims not only did they not consent, but it was assault and battery. So really important to map that out, identify where you need to obtain authorization, have clear documentation that your employees can understand. There might be variation of levels of reading levels, so that you can say, yes, there was informed consent. Lean on the healthcare sector in that regard. When you go see your provider, you consent or have an opportunity to consent to everything from HIPAA to whether your insurer is going to receive the information, to whether third-party billers will receive the information. Really, we want to take our cues from that process. And lastly, the process. So we all know that when we are in a non-emergent situation, non-crisis state, we have policies. We have, maybe compliance reviews your policy, risk reviews your policy, legal refuses your policy, and they're not as time sensitive. And there's a lot of thought and energy that goes into those policies. We also know that documentation, particularly when you have lawsuits that are being defended, documentation that existed at the time is critical. And they'll ask you, what was in place on April 22nd, 2020? What were you doing at that time? So critical, though, in this environment, as the rules change, for example, if EEOC comes out with a position that testing can be required, that your policies, your process, that you have a mechanism in place to rapidly change those and to educate and to make sure that you're separating your COVID stream from your HR stream. But really, I've seen this happen over and over when we get into these crisis modes, that the documentation doesn't keep up with the change in practice and the change in strategies, and that creates liability downstream for companies. So again, flexibility, speed, accuracy, planning ahead will be critical for companies to really not only thrive when they go back to work, but be sustainable in the long term. So happy to answer any questions. Also, I think as David mentioned, I work with a lot of different healthcare organizations that are working through the capacity issues and when you're going to have capacity to treat all COVID patients, and that's going to be part of any kind of return to work, overall public health return to work plan. So happy to answer any questions on that topic as well.
Thanks so much, Delphine. You know, I really love the metaphor of fine-tuning the radio. You know, every single day we get new information, and you know, it's almost like what you say 3 days ago has been completely invalidated. And you know, what we're telling our clients is, you know, put a process in place, put a framework in place, but don't think that it's going to look exactly the same way tomorrow or the next day as opposed to today. Just make sure that the framework and that you can adjust accordingly as the new information comes on. So I really love that metaphor. So I have a lot of questions here that have already started. So I will just read them out and feel free to start asking them. Hello, thank you for assembling this innovative team. You're welcome. Question, how would you recommend PCR screening for COVID-19 in light of current shortages as employers attempt to return to work? For it to be impactful, do we have to test a certain percentage of the employer's population? Okay, let me take that question. It's a big question, and I know who asked it, and is a good friend. Thanks for that. The truth is that we're now advocating, at least in the short term, for public health purposes, to look at antibody testing. The sensitivity and specificity are pretty good. The tests can probably be more available. You know, looking at the IgM in particular, you'll have a sense of who, in fact, can potentially be transmitting. The issue about the IgG is probably less important when the prevalence of infection or immunity is fairly low. We really have a PCR availability issue. And candidly, as it relates to employers, I don't think employers would feel pretty good about competing for these really needed diagnostic testing that the hospitals actually need today. So our view is that that at least in the short term, to focus on trying to get an adequate screen, and if you can, we're going to choose at EHE, we're going to choose an antibody screening test. They're simple, they're point of care, they take 10 or 15 minutes, they're fairly inexpensive, they're reliable in their collection, and as new and better tests become available, whether that's a point of care PCR test or others, consider moving to potentially some of the other testing. You know, our view is, if possible, and if there's enough availability of tests, that employers should probably screen everybody before they come back for the very first time. You would probably take out a whole bunch, you know, at least 90% of those people who are actively transmitting a virus, and that would be a huge jump in the reduction of potential chains of transmission as they come in, and then to assiduously follow everybody thereafter by daily taking temperatures and asking them if they've had some close contacts. But I guess this whole testing thing this is a story yet to be told, and it's, you know, we'll be talking about this for a long time. There'll be a lot of things look back in retrospect, but frankly, this is going to be an ongoing issue. But the short answer for us really is looking at antibody testing. There's a number of studies now that are using the antibody testing as a good public health as opposed to diagnostic tactic. And for employers, we're not really trying to find sick people to send them to the hospital. You know, I kind of look at the employer return to work strategy and safe at work strategy as a micro public health activity, and to use the antibody screening as a good first step in public health screening. Who should the contact tracing responsibility fall on? Employers or public health organizations? This is an excellent question, and I think and I think it's a bit of a confusing question. And we've had discussions with Delphine about that, and I'm going to let her take to answer this in a minute, but we had a big discussion yesterday and said you need to distinguish the obligation of the employer to provide a safe workplace and to contact trace internally versus externally referring to public health authorities, because it's not the purview, family, friends, and the like, of an infected employee. Delphine, I'd love it if you could pick up on that. We talked about this at length.
Sure. And, you know, I think part of the confusion, at least that I'm hearing from clients, is where contact tracing, what exactly does it mean, right? Are we talking about what happened? And there's a great video actually that David shared with me on the process in South Korea? Is that what we're talking about, where the government is tracking everybody? Or are we talking about what, in large part, we already did, where we say, okay, person on third floor in cubicle 10 was infected, and everybody in cubicle 11, 12, 14, 15, 16 should be notified. So where are we on the spectrum? So we had a big discussion yesterday over the employer's responsibility ends, or it begins and starts with your let's say, campus. And your campus could mean one floor of a high rise, or it could mean, a large area. You are not responsible for, because in the media we hear some of this. Well, what if people go home on the subway? I would argue you are not responsible for where your employees go after work. To put that responsibility on you would be unreasonable. You could ask an employee where they go after work, and they don't have an obligation to tell you. And how are you going to find out if it was true or not? So it's in your workplace. Now, if you also ask employees to, maybe if you have employees who deliver packages to other locations, then the contact testing would extend to areas where you sent your employees, if that makes sense. But if it's, it's within. So let's say, again, you have an employee who tests positive with COVID when they have their, let's say if you implement a weekly testing process and they come back positive, and then it's tracing and saying, okay, where was Joe last week? Who was at work? Maybe your people are going back in phases. Who was with Joe at work in the last 14 days, and tracing that. So it's not a great, I think some employers have interpreted it as, you need to monitor all of your employees 24/7, and that's not what we're talking about. Now, another question I've gotten, and I don't know if this is part of your question, is who within an organization does this? Is this HR? Is it security? Is it their supervisors? In that, I would suggest, but this is not a legal recommendation, it's an operational question, is it with your COVID team? And when we talk about process, and you have your sort of general HR process, and then your COVID workflow, and there may be some overlap, but it stays centralized with that team, because part of the process and the management is, this is a ton of data that's going to be coming to you constantly. So to have, again, one platform or one way or one group of people who are focused on this.
Super. So the next question is for Justin. I'm going to kind of shorten it, but to get the gist of it is, considering this huge iceberg under the surface and considering where some of the cities in America currently are, how do you know, the question says, how do you know exactly how to conduct yourself in a return to work scenario in a city like New York versus somewhere else in the country? And I'll say, Justin, you and I have had a lot of discussion about this, and I know you have personal opinions, and that's perfectly fine. You can render your opinion. They're not necessarily the opinions of EHE Health, but I think your opinions are interesting. So go ahead.
So yeah, I think that actually New York is a great example, because it's one of the few places we actually have the most data. And actually that's where I've been focusing a lot of my efforts. New York, I think, is in a position where we've had quite a large proportion of people already being infected or recovered. So you've actually had a depletion of the number of susceptible people that are there. I think that together, putting it all together, you actually see that New York is probably in a position where it's on the downward slope that David was talking about. In contrast, there's other places like Chicago where you had an early lockdown coupled with a city that was, even at the time of lockdown, earlier in its epidemic than New York was. And it's much less clear in some place like Chicago, one, the true prevalence just in the city, and two, what's going to happen once lockdown is released. I think that ultimately the answer to this question is probably going to rely on public health measures in individual cities, potentially even coming from the private sector. But I think that we need some more data to actually get a sense of what is the true prevalence in these communities.
Justin, this is my question, but I think it's worth talking about with the audience, which is, you've given me some kind of lower band estimates about how many people you think, may have actually contracted disease in certain cities like New York and Boston and others. based on some of your own studies, as well as some of the antibody screening, plus some of the antibody studies or testing studies that were done, for example, for in New York with the admissions for women into labor and delivery. Why don't you give people kind of a 2-minute overview on all of the accumulating data that you're starting to see about what the true prevalence of this is in a wide variety of places in America?
Yeah, so I'll start with New York. New York probably has some of the best data, and starting in late March, there was a study that came out of Columbia, the labor and delivery floor, as well as New York Presbyterian Hospital. And it actually showed that there were 15% of women admitted to labor and delivery. And now, importantly, these are women who are otherwise healthy, but are coming in to give birth, who were actively infected, most of which were asymptomatic. So this is nearly 2 weeks ago, a little over 2 weeks ago, you had 15% of women testing positive for SARS-CoV-2. Now, I think this is not just antibody screening. This is not just saying that they were positive at some point in the past, but actively infected. Thinking about just that you had 15% prevalence at any one period of time is pretty remarkable. I mean, it's definitely something that we don't see with other diseases. Partly, there's a bunch of reasons for that, but it's really a remarkable result. And when you consider the number of people who were likely infected before that, making it possible to have 15% infected then, plus the fact that this has also been going on for another 2 weeks, I think it's sort of hard to imagine that New York has an overall prevalence that's less than 30%. This is a truly massive proportion of the population. There's currently, we've been working with the task force, the COVID task force of Cuomo's, to try and put together a larger sero study there, but that's currently the best study that we have from New York. Boston has somewhat similar data. There was a study that came out, I think, about a week ago, PCR-based study of the homeless population showing nearly 50% active infection, mostly asymptomatic again. This has been followed up. The paper has not been made public, but I think the Boston Globe has reported on it, that the lead authors are saying that completely random sero survey of the population, 1/3 of people in a county just outside of Boston were positive, so had antibodies against SARS-CoV-2. There's been a lot of discussion of some studies coming out of California, one in Santa Clara, and the other in Los Angeles, both showing somewhere on the order of about 2 to 4%. These studies, while they are still very much in line with our predictions, unfortunately that low a percentage, which is kind of what we would have expected, falls into an uncomfortable band where the specificity of the test makes it so it's hard to interpret those results. But really, so at the moment, it's primarily New York and Boston that have the best evidence. And then otherwise, you have to start looking internationally.
Wow. That's all I can say. That's a lot of people who are infected and walking around with this shedding virus. Okay, this is going to have to be Delphine because it's an ACLU question. Given the information released by the ACLU yesterday, how do you see this impacting strategy around contact tracing? I don't know what the ACLU said, so I'm...
So are we talking about abortion or inmates? Which, because the ACLU has been active in a variety of areas around COVID.
Why don't you address both of them? If I don't know.
I don't know if the person can follow up. Okay, and also generally on tracing. So the issue around abortion is that certain states are using COVID-19 as the ACLU's position. They're not alone in taking this position. As a way to stop abortions, and that most states, as you know, have stopped non-essential surgeries and procedures, and that's why you're not going to, to get your sinus surgery these days. And that certain states have left it up to the providers to determine which ones are essential, and other states, including Texas, Alabama, Arkansas, Iowa, a couple more, are putting abortions in that category. And as we all know, abortions must be to be legally performed within a certain time frame. And unlike, again, your knee replacement that could wait 9 months, that's not a possibility. ACLU has also been coming out on releasing inmates, and we've seen, I can't remember, it's Ohio, but one of the prisons where they actually were releasing some of the inmates, there's the rates of COVID, and I don't know if Dr. Silverman's looked at this at all, in jails is, you know, I think we're going to see the numbers are going to be incredibly high. So the ACLU's come out on that. They've also come out on limitations on contact tracing, and saying that, you know, there are flaws in some of the government's approaches, including, you know, some of the approaches that were used in certain Asian countries, including South Korea that I mentioned earlier, and that the tracing's not reliable, the information that's shared with public health officials isn't reliable, and that's an invasion of individual rights. Now, the ACLU is active. I mean, they're also talking about immigration issues, but I'm assuming that's not what you're addressing.
I got a clarification that it was specific to COVID application development and usage privacy around PHI. Have you seen?
So specific to COVID? You know
the
what,
question on the ACLU was specific to COVID application development and usage privacy around PHI.
Oh, okay, so app developments for COVID. Yeah, they're concerned, as I touched on, and happy to have a further conversation with whoever offline. Of course, they're concerned. I mean, everybody's concerned around the ability to not just, there are apps that are being developed right now where your employer you could consent to have your employer have that information. Some are focusing on just where were you while you were at work, right? So they could trace you, make contact tracing easier. Others where your employer potentially could trace you, if you agreed, hopefully, to where you've been outside of work. And if you travel to a cluster that's been identified by someone like Dr. Silverman or public health authorities, that would trigger. Part of the concern is that the data is supposed to be de-identified and it has to be aggregated. And that there's concern that if it's not aggregated and it's not correctly identified, then you do have, you know, PHI, HIPAA violations, you have privacy violations. So on contact tracing is going to create a whole sort of maze of privacy issues to work through. And therefore, going back to sort of our initial conversation about where it starts, where it ends. There are going to be a lot of different ways to do it. If all of your workers come into a factory and don't leave all day, that's going to be a very different conversation than if you have traveling salespeople. And happy whoever's asked that question to have a further conversation offline. I want to be mindful of the time.
Super, Delphine, that's great. Justin, but just on the heels of that question, there's another question. There are a flood of COVID management apps available from various sources. Are they useful in your opinion, and what functional elements are most vital in managing a workforce? So to depart from the legal issues, Justin, I think, you know, you have a specific points of view on the value of contact tracing in America and where we stand now versus how some other countries did it from the onset. You know, and what do you think about these apps, and what do you think the impact on public health can be using these apps?
So I think that the first thing to keep in mind is that it's generally very difficult to actually use some of these apps or surveillance systems to get a sense of what's actually happening on the ground. We got kind of lucky. ILI is one of these places where there's been a lot of research in it that allows us to have a better idea as to how it works, what, you know, if you see something, what that means. But I think especially when we start seeing new apps that are coming out, it's going to be really difficult to, especially these contact tracing apps, to really get a sense for how the data that you're seeing that the app is reporting and collecting is actually translating to what's currently happening. As a result, I feel a little uncomfortable with the idea of these being widely used as a management strategy. That said, I do feel strongly that some syndromic surveillance, for example, monitoring for fevers, just asking people if they've had a recent fever and chills, lack of smell, anosmia, which has been recently reported, some of the other symptoms that are kind of commonly associated with COVID. I do think that those are going to be useful strategies for getting a sense of risk.
Yeah, that's great. And we feel the same way at EHE. You know, sometimes you look at some of these apps, you go on some of the websites, particularly Korea, and you see the way these are so specific. I have a colleague actually in Shanghai who said that for her to be able to be registered to go to work to get a green label, she can't transverse any of the lines of transmission that any bus stop or anybody who's been anywhere. I just don't know how that gets actualized in New York, considering, you know, the prevalence. So I think it gets really complicated.
I think that unfortunately, one of the things that's going on right now is there's starting to become some interesting, but probably unlikely hypotheses thrown out about how this virus transmits. And I think that washing your hands and covering your mouth when you cough are probably just wonderful and highly effective measures. I'm not sure that having to trace if someone has walked through an area where someone else has coughed in the last hour is really a good use of resources. Okay.
Boy, there's a ton of questions. I'm going to try and get some representative ones. So for Delphine, what are the requirements needed to separate return to work and HR processes if one, quarantine for positive tests has a mandatory quarantine period, and two, that quarantine period affects their job requirements and pay schedule, e.g. hourly employees, customer-facing roles, et cetera?
Okay, and we could break that down. I mean, the general construct is that just like you do now, you have your HR, your personnel file for someone that excludes their disciplinary issues, et cetera. And then you have, maybe you'll have, depending on the type of maybe you have a clinic on site, maybe your employees have an executive physical, whatever that may be. They're separated. If you have PHI, you're not including that information in the file that, let's say, that person's supervisor could see. So if they've been on a leave of absence, a medical leave of absence, and they need to provide documentation, you don't include that in the personnel file. The same general construct here. Now, generally, the employers are going to find out whether, you can ask questions about the most common symptoms, whether an employee has experienced those common symptoms. And again, that's your COVID sort of file, your flow. That person's supervisor doesn't need to know they've been experiencing fever and temperature, and that's why they're not coming back. They can just know they weren't cleared to work. You might have people who aren't going to be cleared to work because, they're struggling mentally and they don't have COVID, but they're not fit to come back. So just like you would in any other process where you're separating the medical issues from, let's say, from the, personnel performance issues. So of course, if somebody's having a nervous breakdown and can't perform the work functions, there's going to need to be some conversation between the supervisor and your COVID HR team. And you're using, only the minimum necessary information do you need to share and say, again, my hypothetical Joe is not going to be able to perform X, Y, and Z. It doesn't need to be Joe because Joe is hospitalized for 5 days in an inpatient psych unit. And same with the policies that are supporting those decisions. You might decide as an organization that while, to take certain approaches based on job categories. So, again, different facts, but your general construct of having personnel and medical in two different work streams.
Okay, super. We only got a minute or two left, so there's just so many questions here. Let me go back to one. First of all, several people asked, how do you source testing and antibody testing and the like? The people have been approached by vendors. I prefer to take that offline. We at EHE Health have been sourcing these now for close to 4 weeks and have come to some decisions. And we'd be happy to speak to any of the questioners on this about how we're going about doing it. But next one is for Dr. Silverman. Back to prevalence. Justin suggested the Santa Clara and LA Sero survey were not reliable, but the Boston and New York point prevalence studies were more accurate. Why is that the case? My understanding was that other Sero surveys, including Wuhan, had found a cumulative prevalence of 3 to 5%, not higher.
So I think the major criticism that has currently been going around in the academic circles of the Santa Clara study and the Los Angeles study is that at 4% prevalence, It has nothing to do with necessarily how the study was performed, but literally the antibody test, which has a specificity of only around 95%. So assuming that you test a lot of people, theoretically you could get 5% false positives, that it is unclear whether or not, or you can't really strongly say that the observed 4% prevalence in Los Angeles and Santa Clara is clearly due to 4% prevalence or potentially false positives due to the test. In contrast, at upwards of 15% and at times even as high as 30%, this criticism doesn't hold any weight. It doesn't make any sense, especially in the L&D survey in New York, which is a PCR survey and generally has better test characteristics and a better sensitivity than some of these antibody tests.
Okay, last question, and then we're going to have to stop, and I'll try and answer the other ones by typing. Can you speak to masks in the workplace? How effective are they? Should we be focusing on obtaining a certain type of mask? Dr. Silverman, do you want to take that?
Yeah, so this is an interesting question. I mean, my personal opinion is that there's currently a shortage of N95 masks, but those are the most effective. They are also wildly uncomfortable, having worn them a tremendous amount. Surgical masks probably help with some droplet spread, but they may be minimally effective comparatively. I think that this question is not particularly well answered currently. But and cloth masks and cloth face coverings, they may be useful, but probably not from stopping any droplet transmission, but really just to keep people from touching their own faces. I think that this is really, it comes down to a question of discomfort. I mean, I personally cannot stand wearing an N95 mask. A surgical mask is not a tremendous amount better. And I think that there isn't, it is not so clear that this is going to be the health, that this is going to be the intervention that dominates the spread. So, the
idea of generalized use of masks, as described by the CDC, is not to prevent from getting the infection, but for those asymptomatic people not transmitting the infection. I don't know what the empirical data is.
The empirical data on that, the N95 masks do stop the spread. They are also, again, awful to wear. The surgical masks, there have been more, there's been a few studies on either side of this, some showing basically that when you cough through a surgical mask, you know, that's not really what these things were made to really stop, these small viral particles. Probably still better than nothing, but again, I think the key question is whether or not wearing a mask is going to be a dominant reduction in the risk compared to better hand hygiene, making hand sanitizer readily available, screening as Dr. Levy is suggesting, that kind of stuff.
Okay, I'm going to have to end it there. We're a few minutes over. This has been incredibly interesting and stimulating. Really appreciate you joining us, Dr. Silverman and Delphine O'Rourke. We will take any more questions offline. We'd be happy to receive emails and to continue our conversations with all of you who are on the website. And of course, you can always access our COVID-19 microsite as well as our helpline. So thank you very much for joining us, and stay safe, stay healthy. Thank you.